So yes, it does happen, but it's very rare. Our procedure for unknown primaries at our institution is such that if we do not find something on a careful clinical examination, we always then take the patient to surgery, treat the neck, do an ipsilateral tonsillectomy, again, carefully palpate and look again the tongue base. If we see or feel anything at all, take a biopsy. If all those evaluations are negative and there is not a reason to give additional treatment to the neck based upon the status of the neck disease, we use no other treatment, no radiation, no other treatment. And I can tell you, we've reported this in 2 papers, and the incidence of having a primary discovered utilizing this method is extremely rare. It is less than 10%. And so it's not something that you have to routinely give people radiation therapy throughout the head and neck area. In fact, one of our series had no cases ever discovered, one had 1 discovered, and that was with long-term follow-up. There is something to be said for the fact that if you can't find a primary, there may be some immunologic surveillance that allows the primary site, the body's own immune system, to get rid of it.
And I think, thank you very much, this is exactly the situation. Your case you described, this is not an unknown primary because you palpate the tumor. For all the subgroup, without palpating the tumor, and so this is a real cancer of unknown primary. Yeah.
Professor Glanz?
I would like to come back to the limits of the medication.
It's okay. Speak loud.
You mentioned the upper margin, that's the skull base, but you didn't mention the lower margin, and this might be the lymphatic ductus lymphaticus or the lymphaticus dexter. And what are you doing when you have a metastasis fixed to the ductus lymphaticus? Do you leave the metastasis and ask the radiologist to give a boost there, or do you try even with a microscope, to remove everything, and then you have a damage, you have a lymph fistula, which might be very challenging situation for the patient? What would you, the head and neck surgeons, what would you recommend to do when you have a situation like this? This is the first question. And the second was, how long do you wait after concomitant chemoradiotherapy with the neck dissection or the removal of a suspicious lymph nodes in the neck? 2 months, 4 months, 6, 1 year? What would you suggest?
You're right, you have limits above and
limits
below,
down.
That's normal. And if you have if your decision is to try to cure the patient, then you must try to remove the cervical mass. And if you have infiltration of the ductus lymphaticus, ductus thoracicus, then you must resect it and you must close it. I think that's my opinion. But sometimes you have tumor behind the clavicular, then it could be really, really difficult. And only in certain cases it makes sense to open the clavicular and to remove the tumor behind. But in some cases it could be, in my opinion, if you'd like to cure the patient. We know if you have a R1 or R2 situation in the neck, you can irradiate the patient, but normally you can't cure him. That's the point. And therefore, if you decide to try to cure him, you must try to resect the tumor completely. Sometimes you can hurt the phrenic nerve, you can hurt the plexus brachialis. You must talk to the patient before the operation, and you have to make the decision during the operation procedure. And this is what Jochen Werner meant. Sometimes it's an individual decision for the patient and for the physician. After concomitant radiochemotherapy, we wait normally 3 months. After 3 months, we perform endoscopic examination after having a CT scan. And if we find no tumor in the primary region, but we see suspicious lymph nodes, then we perform a neck dissection. If we have no suspicious lymph nodes. In the CT scan and/or in the ultrasound, we do not perform a neck dissection, but we perform follow-up examination of the patient.
And how often did you find non-vital residuals of tumor remnants or scars? How often in your experience?
We know that it's possible that you see in the ultrasound, you see a lymph node, and the pathologist says the cells are avital. We know this.
Non-vital.
But if we see a node, we perform the neck dissection before 4 months after concomitant radiotherapy. Because we know if you perform a neck dissection later than 4 months after concomitant radiotherapy, you have a higher morbidity of the patient.
Thank you very much. I think you have a take-home message. So I conclude. We covered the indications for a neck dissection, the limits of the neck dissection, of a re-neck dissection, and also the carcinoma with unknown primary. And thank you very much for your attention and the panel for the very active.